This conference will now be recorded.
Okay, we record our meetings, this particular meeting, because a lot of guys can't be on all the time, and there's some vital information that's pertinent to many guys with advanced, recurrent, and aggressive disease, prostate cancer. So we kind of archive it, and some people can go back and listen to it again, or listen to it when it's more convenient to them. So disclaimer: we do receive some funding generously from Bayer and Pfizer. It's the first time that they've supported support groups, and we appreciate them recognizing the vital role we play in this crazy journey. So we thank them. It's going to be a busy night tonight, so I'll try to keep it moving as fast as possible. Try to keep it tight the best you can, and avoid too much extraneous stuff, because we've got several new people and a lot of other regulars who want to bring us up to date with some things, and we have a topic that is vital to us all that we want to consider as well. So with that short introduction, as I said, my name is Peter Kafka. I'm moderating this from Maui, Hawaii, which is my home, but I spent the summer months in Minnesota, and I'm heading back there in a couple of weeks. So that's all from me. I'm going to introduce, so Alan Babcock is not new to me. He's been participating in our low and intermediate group for a while, but I'm going to let him kick it off quickly, because he was the first one on tonight when I opened the meeting, and he is all of a sudden in the recurrent stage, even though he just had treatment several months ago. So I'll let Alan quickly describe what's going on and what his concerns are. Is that okay?
Yeah, thank you, Peter. Let me just run through. So I had my prostatectomy on February 10th. And at that point, my Gleasons were 4+3, and I was in group 3. The pathology report came back, and it was not good. They upgraded me to 4+4. I don't know what I consider that an upgrade, but I went up to a 4+4, and they found periprostate fat, cancer cells in the periprostate fat. And Dr. Correa said, yeah, at some point you're going to get radiation, but I don't think it's going to be right away. Nothing in the seminal vesicles and nothing in the lymph glands. So I was kind of a happy camper, I think. Went back April 8th, I think, or 5th, that week, and took a PSA, and it was 0.05. I was hoping for a 0.0, for 0. And Dr. Chris said, wow, maybe it was just a really sensitive lab. I'm not worried about that. That can come under, almost undetectable, almost being the operative word. So I was still feeling pretty good and working on stuff. And then on June 28th, I went back for another PSA, and I was like, okay, I expected maybe it'd go up a little bit, but not much. And it came back 1.14, which absolutely blew me away. So my brain said, okay, you've got this really aggressive cancer. I sent, I think maybe Joe told me to do it, Joe Gallo. I sent Correa a message saying, I'm freaked out, I'm stressing here. And he actually personally called me and said, calm down, Alan. It's not as bad as you think. And we'll see you next Wednesday. He called me on a Friday. He said, I'll call you next, we're going to meet next Wednesday. Yeah, I'm not meeting virtually. I'm meeting in person because that's better for me. And so at our meeting, he said, yeah, I'm going to refer you to Dr. Wong, who's a radiation oncologist. First appointment I could get with her was on the 29th of July. So my emotions have been going like a roller coaster. When I left Dr. Correa, I was high as a kite. I texted my friend saying, okay, Dr. Correa has a plan. This is really good, and he said, oh yeah, radiation now, 90% chance we're going to get rid of that cancer. So I was like, oh man, I got this licked. Went away for 4th of July weekend, came back, and as I'm wont to do, I started doing a little research on radiation therapy, and bam, I crashed again. And I called down to Fox Chase and said, can I see Dr. Wong earlier? And they said, not likely. So that's my story. So my questions are, do I go for a second opinion now, or do I wait till I see Dr. Wong? In my house, there are mixed emotions about that. Dr. Correa said, Alan, if you want a PSMA PET scan, I'm going to order it because I want you to feel comfortable. But I got to tell you, chances of them identifying your cancer using the PSMA are slight to none. When they go after this, so it looks like, I think what I'm going to be confronted with is pelvic girdle radiation. Is that one of those situations in which there's a way to protect your bowels? Because I really don't want problems with my bowels and with, that kind of thing. And then trying to put together a list of questions to ask radiation oncologists.
Okay, well, let's slow down a couple of seconds here. And some of us will weigh in. The bowel protection is usually for guys who still have a prostate, and you've had a prostatectomy. So that's probably not an applicable thing. The question is, you want to talk about different kinds of radiation, and the PSMA scan, you said your PSA is over 1.1 now?
It's 0.14.
0.14. Okay.
Yes. What I read online said, it's got to get up, I think, to a 0.5, but I just read one article.
Okay. I misunderstood. So before it was a month ago it was 0.05.
Correct.
Now it's 0.1 something in a month.
4. Yeah. Tripled, went up 3 times, almost.
Okay. Well, don't panic. It's still low.
Oh, I've already done that.
This is not the end of the world. It's not even around the corner from the end of the world yet. But does anybody want to weigh in with some questions? I want to ask the radiation oncologist.
Yeah, I mean, the first thing, Alan, is that Dr. Correa's right. There's no point in you doing a PSMA scan at this point. And the best thing to do is to wait until the PSMA gets up a little higher, and to watch it, and maybe even to defer any radiation treatment or any treatment so we can actually see where it is. Because if we can see where it is, it's more likely that the treatment can be tailored to you and it's not going to get out of hand. Now, we normally think that the lower limit is 0.5 and really 0.65 to get a good result, because that was the trial, and I always get them the wrong way round, but I think it was the Osprey trial that was the recurrence, and the Condor trial, but I'm not even going to say, but there were 2 trials, and one was for recurrence and the other was for early detection. The early detection one, they started at 0.2, and they did get results. So we know that between 0.2 and 0.5, you can get a result. But ideally, for recurrence, we want you at 0.5 or higher, because that's what the trial pointed out, okay? And my suggestion to you is, first of all, you don't want to get a second opinion before you got the first opinion, because you don't know what the first opinion is. So let's not start talking. Dr. Wong is very good. Joe will attest to her. We heard somebody last night talking about her.
She is very.
And my recommendation is to work on de-stressing yourself right now. And I don't mean that flippantly, because the more stressed you are, the more the cancer's going to relish and spread. So think about some de-stressing techniques, some exercise, things like that. That's what I would say. We don't really know where it is, but if they saw something in the peripheral fat, then there was clearly some extracapsular extension. And we've just got to let it get up to a level where we can see it. In the old days, they would wait until it got to a level of 0.2 before they did anything. I think that you know it's there, and just watch it early. And if anybody else wants to add anything, or when they intervened, anybody want to add when they intervened right after surgery?
Can I just throw something in here, Rick? That Dr. Correa said that they have a trial down at Fox Chase, and he is going to refer me, but Dr. Wong will decide if I'm an appropriate candidate for their trial down there, clinical trial.
What's the trial? You know, people think that, trial, magic word, that's going to cure me. A trial, right? Oh, I got to go into the trial. No, we got a problem with trials here, because we know that just the way that men are pushed into treatment in community practices to make money, the doctors in centers of excellence need candidates for their trials. And so we're a little circumspect because we've seen people enlisted for trials that weren't appropriate. What do we need a trial for? We know what you're doing. Come back, tell us what the trial's about, just have him send you the trial protocol, and then we can talk with you whether it's appropriate or not. Yesterday, we talked about a trial where a guy was going to get early darolutamide. Probably was a good trial. But just because it's a trial doesn't mean that, you want to run into it.
Right. So Alan, my suggestion would be to, you're one of those rare guys that really likes to do the research and prepare, and you know the stuff inside out. Take the time to really study up on the different radiation protocols, because there are numerous ones, so that when you go into Dr. Wong, you can really talk her language and see what options might be available to you, what would work, what she might be skeptical of, where she thinks there are limitations. But take the time to do that now, so that you're ready for that, because most people get blindsided when they come to radiation and don't really know all the terminology and so forth.
Okay, reading on last night. Well, I've been reading the side effects of radiation therapy, and that kind of put me into a tailspin. But yeah, no, I didn't look into different protocols, so thanks for that.
But I wouldn't worry about it too much. Very few of us on this call, many of us have had recurrence and radiation of one kind or another, and very few of us really have terrible side effects. During the thing, you might have some bowel upset or this or that. Afterwards, it doesn't. You'll be okay. You'll be okay.
Thanks.
Okay.
Can I say one other thing? Alan,
Yes,
yeah, I can see that you're really wound up, and I was the same way when I was first diagnosed. But I will tell you, being in AnCan totally relieved all of my anxiety. And another thing that relieved my anxiety was meditation and learning how to be in the moment, because this moment right now, you're alive and you're well. You're not dying tomorrow. You're not dying the next day. You're up vertical and you're nice and healthy. Just enjoy every moment. Don't let this moment kill tomorrow's moment.
Yeah, and
worrying about tomorrow kills this moment.
Yeah, I started a meditation program, and Dr. Correa suggested I add yoga to it, so I'm going to start, supplementing with yoga. And he also told me I could get back on my bike, and that made me a happy camper.
Very good.
You'll be okay. You've got many years to go. You'll be okay, and we'll guide you through it. You're going to be okay. Promise you.
You were worried about 0.05. Less than 0.1 is considered undetectable. And so 1.4 is you're just above undetectable. That's why people are telling you don't panic.
Yeah,
Okay.
this is John. I think most of us would love to have 0.05, but you are really bringing me back, Alan, a couple of years, and panic included. My PSA tripled between 6 and 12 weeks after my prostatectomy. So a couple of things. Rick knows a lot more about this than I do, but I fully agree with everything he said. From what I understand, the chances of this little tiny scrap of remaining cancer being in the pelvic region are extremely high. And radiation is very good treatment, and it can be quite lethal to cancer. And I think, speaking for myself, and I think most of the guys here, we all tolerated it very, very well. I mean, I had a period of time of diarrhea during my radiation, and then it cleared up by a couple of weeks after the radiation, and I had very little in terms of other side effects. I think it gave me sort of a reverse suntan on my skin, which was weird, but I tolerated it quite well. And your PSA is probably going to go even lower than it is a couple of months after your radiation. And as far as your anxiety, if all the yoga and meditation and exercise, if it still leaves you with a great deal of anxiety or sleepiness or sleeplessness, go ahead and take some medicine for it. What the heck, for a couple of months, you're not going to get addicted to it. It helped me at the beginning as well.
Yeah, and the good news is
Can I just add something?
Okay, we got to move on quick, so go ahead, Rick.
Okay, so I just want to add that we don't give medical advice on here, as you know.
Oh, sorry if I overstepped that.
There are certain exceptions. There are certain exceptions to that rule. And when you have a license and you've spent your life as a practicing psychiatrist, you're allowed to tell people to take psychiatric medicines. So the reason we make exceptions for Dr. John is because he has the right credentials. Okay, Alan?
Sure.
You keep me in line, Rick. Go ahead.
Well said. Okay, Alan, we're gonna move on, guys, because we've got.
Peter, I'm just going to throw in that if Alan wants to discuss the process with Dr. Wong, he can give me a yell as well. She is definitely very open and definitely very available.
Thanks, Joe. Okay, we've got several new people, and the protocol with people who are new is I've got a questionnaire, and I'll try to move through it pretty quickly so that we can get to your concerns. So Tom
Cinquegrano has been here before, Peter.
Yes.
So I think we should just give him some time when we get to the questions. He'll fill us in briefly with that. Let's not consider Tom as a new person, and we'll get to Tom with the questions.
Meaning, ask him the questions or leave it?
No, when he has a question, he wants some time. When he gives us some time, he'll fill us in on his background.
Okay, well, he was one of the, okay, so I'll go to a couple of the people who are new. So I've got, you said Steve and Linda Geringer are
yes.
new.
Yep.
Okay. So you want to introduce yourselves? I'm going to focus on, I'm not ignoring you, Linda, but Steve, how old are you?
76.
76, okay. And where do you live?
Nashville.
Okay. And when were you first diagnosed?
Approximately 2 years ago with, advanced with prostate cancer. Stage 4.
Did they give you a Gleason score?
10.
10.
I mean,
5 + 5. Okay.
Chemo. Oh, I'm sorry. Go ahead and ask, please.
Okay, so Gleason score 10. And where are you being treated? What doctors are you seeing?
Vanderbilt Cancer Center.
Okay, that's good. And
we've been to Houston to Excel Diagnostics for one round of Pluvicto, and now we're going to stay in Nashville. They have it now.
okay. What other, besides Pluvicto, what other treatments have you had?
Docetaxel. I mean, basically it was just chemo, of which I had no adverse effects.
Okay.
And radiation oncology Vanderbilt also, my knowledge of the disease would not fill a grain of sand, as opposed to you gentlemen. What attracted me was the fact that you're willing to talk about it, because we all stuck in our egos, and that's kind of weakness to one of strength. So,
you bet. So was there any other kind of chemo, just docetaxel?
Twice, and then I also during that period had a melanoma. So,
oh, okay.
No, and I went on a between chemos. I went on a drug called Xtandi, which did not prove effective. So back to chemo. Then it was like I wasn't on anything. It was so easy in that sense.
Have you had genetic or genomic testing? Has that shown anything?
He has, but honestly, we don't know.
We haven't seen results yet, but yes, I have.
PSA at diagnosis.
PSA at diagnosis.
At the time, when?
A couple years ago, first diagnosis, certainly 5 or less.
Okay. And what? Okay, good enough.
Today it's
so 2 years. It sounds like you've been around the track a few times. Like many of us, but many of us have a little more time in between.
Yeah, but I remain optimistic and encouraged. That's what keeps me, frankly, going. And you know, I don't know anything much about it in terms of certainly the depth that you gentlemen have. It's the idea of just talking about it and being with people who have explored well below.
Who's your doctor at Vanderbilt?
Carrie Schaefer.
Okay. So, so you're undergoing Pluvicto, and it's back on track now. You've started it already.
Yes, I've had the first treatment already.
Okay. So, you want to condense it to? I mean, if you had to ask, if you had you'd have many concerns, but what would you say are your main concerns that we as a group might be able to help you with? Because some of us have been through Pluvicto, so many of us have been through chemo. I mean, many of us have been through all kinds of stuff. But how can we best help you? What are your real concerns at this moment?
Frankly, being part of the group and listening to you is the most helpful part for me. Just seeing the, I don't know what I would call it, but you can call it courage, openness, the discussing each other's issues, and so many of you with so much knowledge to be able to just what I've heard the last 20 minutes. Okay. So all that's extremely helpful. I don't have a scientific mind. I've always been a pretty upbeat person. So that is a very big help to me.
Great.
I appreciate it very much.
Your metastasis, is it confined to the bones? Is it in soft tissue? Do you know anything what they found?
In the spine. The spine.
There's some near the spine, and I'm now and it's most of it's been kept at bay. And I've also just recently gone through another 5 radiation oncology treatments at Vanderbilt. Someone I respect very much. So we'll see.
So at this point, it's been limited to bone. It's not in soft tissue. It's not in. They haven't found anything in your liver or anything like that, right?
Yes, they have.
They have.
They have.
It's been kept at bay in my liver. They're not concerned particularly about my kidneys or my liver right now.
Okay. Does anybody want to speak some words?
Yeah, one thing I think we have to do, and Linda, we've spoken about this, is you need to ask for a copy of any of the genetic and genomic reports that have been done. So, you know, the germline, the genetic reports, which are the ones that are done from saliva, just get a copy so you can talk to us about them. And then if tests have been sent to Foundation Medicine, and they should have been, and I think you said they were, you need to get a copy of that and share that with us.
I'm sorry, I
So
don't know
we
what
can,
I don't know what you're saying. A test sent to Foundation Medicine?
okay, if the there's genetic testing, which is the saliva, and then there's genomic testing, which is the actual tumor. And both of those should have been done. And the genomic testing can be sent to a bunch of different places. Foundation Medicine is just one provider, but you
Okay.
need to get a copy of the genomic testing results for your files, and then you can share that with us, because that might indicate certain treatments that are available. In the meantime, Steve is pretty well covered because he knows he's got another 5 Pluvictos coming up every what is it, 6 weeks?
Every 6 weeks.
3 weeks, is it?
Every
Six.
six.
6, that's what I thought, 6, yeah. 6 weeks apart. So, we'll be seeing you. And I want to tell you, there are guys on this call right now who have finished those 6 treatments. Some of them have had very good results, and some of them have had less than good results for various reasons. But the one thing I did want to say to you, Steve, is that, and this is for everybody, if you like the idea of men talking to each other about their condition, we have a fantastic group called Men Speaking Freely. A lot of the guys on on the screen right here attend that group. It's on the 3rd Thursday of every month. So this month it'll be on the 21st. And I think I signed you up for it. And that group talks about everything except treatment. Because we talk about the treatment here, but that's to talk about all the other issues that cancer is creating in your life. It's a men-only group. So you can come in and talk about your care partners, although I think you have a very good one from what I've encountered. You can talk about how it affects your family. You can talk about whatever you want to talk about, but it's a terrific group, and we'd encourage you to be part of that as well.
Thank you, and you can expect it.
Good. And I just a word to everybody here. Steve and Linda and I have talked. Steve has a good team. He's got 2 young docs, a young GU medonc who has been out of school a couple of years, but she seems to be very well qualified, and he likes her, and so that's good. And if we see something that's not quite right, we'll raise it with you so you can talk to her. And he's got a young and very good radiation oncologist who does a lot of prostate cancer work. So the team around you is correct. And the reason that Linda called me was because she was wondering, should she switch the Pluvicto treatments back from Houston to Vanderbilt? And I said, if it were me, I'd absolutely do that, because Steve got his first treatment in Houston, but now he can get the balance of his treatments at Vanderbilt, so they don't have to travel. And I think that makes perfect sense. And it just so happens I noticed that the new director of the Comprehensive Cancer Center at Vanderbilt is a doc that we know and I like very, very much. He's a doc that specializes in male breast cancer, and we have a very good relation. AnCan has a great relationship with him, so I've just been in touch with him over the weekend too. So I think you're in good shape. Would you like to speak to anybody who's done Pluvicto?
If there's any, yes, that would be great.
Al Latimer, you're on. You've gone through it, right?
Yes, hi. Let me try to get my camera going here. See if it'll, oh no, I can't get the camera going.
It's okay.
Max.
We hear you.
Yes, I have done all 6 treatments. I assume before you started, you had a PSMA PET,
Yes,
and you also had a PSA test
yes.
before you started. And what was your PSA when you started Pluvicto?
It may have been in the 20s. I'm
May have been 22.
In
Currently,
the low 20s. Okay.
yeah, currently
So,
low 40s. Yeah.
So I had Pluvicto every 6 weeks, and after the 3rd week, each time I had another PSA. I had blood tests that were testing for certain things concerning, including PSA. And I don't know when did you finish your first Pluvicto?
3 weeks ago.
3 weeks ago. So are you due for a blood test soon?
yes.
Yes.
So my PSA went from 60 to 10 on the first treatment. And by the time I was done, it was down to 1.5. So 1.4 rather. So that was great news for me. But now I'm 6 months past having finished, and my PSA has been rising again. So, and I've been talking with the doctors about it, and at this point, they don't really know. So I had a great response to it, but it did not last at all. So that's my story in a nutshell.
Can you get
Right.
Do you have any particular questions?
Can you go back to the treatment?
The doctor that I had my treatments at UCLA. So I live in Florida, so you were talking about traveling. I did a lot of traveling for it. But the doctor says yes.
Yeah,
We
at this point,
should just say that Al's a little different because unlike most men who got it, he didn't do chemo first. So that may be a fact. I'm not saying it is, but it may be a factor. The person I think that I'd like you to hear from very briefly is Dennis McGuire, because I saw that he was on. Dennis, you want to talk about your quick history and how far you are into it?
Treatment of Pluvicto. My first 3 were in a clinical trial, and then I took a 6-month break, and then I restarted under an expanded access program, and I've had 5 treatments under that. My 5th treatment was actually on Friday. I've had a good response to Pluvicto while I'm on it. So, and I'm scheduled for 1 more.
And that good response has taken Dennis's current PSA. When he started this second round, it was up around 300, and he's down to 4 or less than 4 now. Dennis.
Yeah, just a little below 4 right now. When I started in December, it was at 300.
My God.
Sounds awesome.
yeah. So Linda, the answer to your question is, I mean, this is a pretty new therapy, and the standard of care is 6 treatments. What happens after that is still kind of up in the air. I mean, there's people do get results, but then what happens later on? Can you get more? I don't think there's an answer to that yet, but I'm sure that there are brilliant minds working on this, because I mean, they know, they see the response factor, but how much you can take, how much, I don't think the trials have been done yet for that. So you got to stay tuned and work with the technology that we have, I guess.
Elma,
So,
can I
let
interrupt
me
for a
just,
second, please?
Let me just comment. Hold on a minute, Ed. Let me just comment on that. So I met virtually with Novartis Advanced Accelerator Applications last week, and I asked them if they are doing any trials for recurrence. And they're going to raise that and see if they can get an arm going for recurrent treatments. The one thing that they told me, which is really positive, is that with a similar radionuclide drug called Lutathera, which is used for neuroendocrine tumors of different types, colorectal, pulmonary, and other neuroendocrine tumors, they have done extensive studies on recurrence, and they have found no safety issues that concern them. So we know that radionuclide treatments with lutetium directed at a different type of cancer can be administered more than once. And so we're on them on that, and we're trying to encourage them to look, because there's a lot of guys on here, like Al and others, who may respond well initially and then want to go back a year to 2 years later. We do know that the treatment probably lasts only 12 to 24 months. We know that because we've seen that. The other thing I wanted to say to you, Linda, and Steve, is that I think you mentioned that your PSA's risen since the first treatment. Not unusual. Not unusual. I think Dennis went up to begin with. Al did not, but don't get discouraged. There's a lot of reasons why that can happen. A lot of reasons why that can happen. And we've had guys, enough guys, so don't be discouraged. Mr. Virtue, you wanted to ask something?
Yes, I'm sorry. I didn't mean to interrupt. I was just wondering what the spelling of it. Are you saying Pluvicto?
Pluvicto. Somebody, oh no, you're on the telephone. It's Pluvicto is the treatment. Pluvicto. Pluvicto.
Okay, thank you.
There's something people should be aware of, and that is the results of Pluvicto. And the results have been 1/3 of the people get really good results, 1/3 of the people get okay results, and 1/3 of the people don't get benefit from it. That was the latest numbers we've seen.
Thank you.
And
I don't know that treatment, Pluvicto.
Okay.
Rick, this is Al. Dr. Calais, the doctor I'm using, he says that they have repeated Pluvicto, and he's suggesting at some point I repeat it as well. Although we haven't gone into any detailed discussions about it yet.
Okay. I will follow up. Thanks, Al. I'll follow up with AAA, because I asked them specifically if there were any trials, and they were not aware of any trials for recurrence yet. But
well, I don't know if they were doing it just at UCLA, whether they were doing it within a trial or not. I don't really know, but he said that they have repeated it with mixed results.
Okay.
We'll check. We'll follow up on that and check onto it. So Steve and Linda, stay with us. Keep in contact, because.
Can I ask one question, please?
Of course.
I saw on Steve's appointments that he's got the lutetium set up, and then on the same day he does have the Lutathera, which I didn't understand.
Well, first of all, I can't imagine they'd be giving him lutetium and Lutathera on the same day. That is weird to me. Do you have a recurrence with your melanoma, Steve?
No, it stayed same numbers the day that they made it. No, they're less than a 30% chance of growing is what I'm told.
Okay. So I think it's just an error, Linda. You might want to just pursue, because there's no reason that Steve should be getting Lutathera.
Okay.
He should only be getting Pluvicto.
Yeah. Okay. I'll call. Thank you very much.
Sure.
Okay, so we meet weekly. Today's meeting is at 6 o'clock Eastern time. The alternate the next week will be Monday, and that's at 8 o'clock Eastern time. We float back and forth between that. Tuesday's meetings are 6 o'clock Eastern time. Monday meetings are 8 o'clock Eastern time. And so this group meets 4 times a month. And, so we're there for you. And you can always email or contact any of us if you've got significant questions or whatever, particularly with all the appointments you have. So hang in there, we're with you.
Thank you very
Thank you.
much.
Okay. I'm not focusing on my thing. Is Peter Godell still here?
I am.
Huh? You are. There you are. I see. Okay. Sometimes it's like Hollywood squares on my computer. I just see. I gotta train my eyes to focus. So you got an idea. So Peter, you're from Minnesota, Lakeville, Minnesota. And how old are you?
I'm 63.
63. Okay. And when were you first diagnosed?
2016.
Okay.
I had a PSA of 58.95.
Okay.
So
good. And they did a biopsy and
they
give you
did a biopsy. There was 7 out of 12 samples that were cancerous. I had a 3+4, and so that was in August. And in late September, I had my prostate removed, and the lymph nodes look clean, the margins look clean. There was a seminal vessel invasion, a small one. Then after that, my PSA started to rise. I think it rise to 0.4 before I had salvage radiation. I always think that's the radiation where they don't know where it is, but they're going to blast the prostate bed.
Right. Back in those days, that's what they did. Yep, me too.
So we did, 34 treatments of that, 7 weeks, which I tolerated very well. But they also gave me a shot of Lupron at the time. So that brought down my PSA. So the second the Lupron wore off, my PSA started to go up. And basically, basically they said it was the Lupron that brought down my PSA, not the radiation.
Right.
So then I had a Acumen PET scan. What? That came up blank. That showed nothing. Then I went into a trial for a year, doing just every 28 days. I had a shot of Firmagon for a year, every 28 days. That brought my PSA down to undetectable for a year, and it was awesome. The shots kind of like stank, but it did the trick. But then when the trial was over, they want to see how long it takes for your PSA to rise. And that was like, I think it started rising like 8 months after. So not too much. And then they did another bone scan and CT scan again. And at that point, my PSA rose to 6, where I was put on, where I went on Eligard. So that was last November. I was on Eligard. And my PSA dropped from 6 to 1.4. And then every 3-month treatment of Eligard, my PSA started to rise again. So it went to 2.3. And past June, it was 4.1. So the doubling time is about 2.6 months. So it's rising fairly quickly. And I just had another CT scan, another bone scan a week ago, and that came up clear. So according to the bone scan, there's no metastasis.
Where are you being treated, Peter?
Minnesota Oncology, in downtown Minneapolis, downtown St. Paul.
Was your Gleason the same after surgery?
Yes. Let's see. Yes, it was. So one thing I do, I keep track of everything. I have charts. I have Excel spreadsheets
Yes,
of every PSA I took.
I do too.
So right now,
who's the doctor that's working
Peter,
with?
let's jump in a little bit here because we don't have a lot of time, and there's a number of issues here. Have they given you what's your current PSA?
as of last week, it was 4.1.
Have they given you a PSMA scan?
Just the acumen scan a while ago.
Okay, and how long ago was that?
That scan was 2019, June of 2019.
Okay, so that's my first question. Second question, because I'm leading to a point here, so bear with me. Second question: are they giving you 6-month Eligard shots?
They're giving me 3-month Eligard shots.
They're giving you 3-month Eligard shots. Okay, so these Eligard shots are not towards the back end of these Eligard shots, your PSA starts to rise. Is that what I'm hearing?
Correct. So I had 3 Eligard shots. The first one brought it down, and the previous 2, it rose regardless of getting the shot.
Okay. Are you on any other drugs?
That's the next step to discuss. The next step to discuss is he suggested possibly putting me on enzalutamide.
Okay. So let me jump in here. All right. The first thing is it amazes me in this day and age that an oncologist who is treating prostate cancer hasn't referred you for a PSMA scan with a PSA of 4. They need to know where this is. They need to get a better handle, and it concerns me. The second thing is, I have to believe that this doctor that you're seeing doesn't specialize in prostate cancer. He's a general oncologist at Minnesota Oncology.
No, he's a specialist. He's a prostate cancer guy. But go ahead.
Well, if he's a prostate cancer guy, I cannot understand how that you haven't had a scan since an acumen scan, and secondly, why you're not already on a second drug, because that's the way we treat this disease today. He might consider himself to be a prostate cancer guy, but he's not reading the research and the literature. The basic treatment now is doublet. Yeah. Basic is doublet, and depending on the extent of your disease, it could be triplet. But he doesn't know. So Peter, we're not gonna cut corners here. So what I want to say is this: you got to get yourself to some expertise. And the expertise, there was expertise that we knew of at Minnesota Oncology. It's not that expertise has actually moved to Masonic, and you have some very good doctors who are real genitourinary medical oncologists at Masonic right now. And if I was you, I would be getting my ass over to those docs as soon as I possibly could. It's beyond me, 1, why they haven't put you on a second drug already, and 2, why they haven't done a scan.
Yeah.
Well,
so the names are Dr. Emmanuel Antonarakis and Dr. Chuck. What's Chuck's last name?
Well, Chuck Ryan isn't. You won't get an appointment, but the other doctor there is.
Hard to get Antonarakis.
So the other doctor that's good, who's there, is Stuart Klein, I think. We can check that out.
Antonarakis. Emmanuel Antonarakis. That's what I did. I'm seeing him. He's a brilliant guy, and he can take care of you. He will understand you. He'll know you inside out, the bottom before you even meet with him.
And he is from where? From
He used to be
Minnesota?
at Hopkins. He's at University of Minnesota.
Okay.
I'm currently seeing him.
Well,
Okay.
hi.
Because
Thanks,
the
Glenn.
reason, one of the reasons I'm not on another medication at the moment is it just started to rise between the last shot and this one. So the
That's not a good reason though, Peter, because the standard now, if they were giving you a Lupron shot or an Eligard shot, they should have considered you already for a second-line anti-androgen. Probably abiraterone, unless you had other medical considerations, because it's better to start with abiraterone than enzalutamide. But if you're not a good candidate for a steroid, or you have other comorbidities, that could be a reason why it was enzalutamide. Again, we don't give medical advice. We're just telling you what the research says. And when the doctors don't follow that, it makes us suspicious. So
Gotcha.
that's why we're saying Antonarakis is one doc, and then the other doc is anybody remember Rob, God rest his soul's doc, was it Klein? I can look it up, but he's gone from Minnesota Oncology over there, and then there's a third one who's gone over recently too.
Okay.
No, but they've got good docs over there.
Okay. Because I know the U of M does have good docs. Because I was thinking of either doing U of M or going, because I'm like an hour and 10 minutes from the Mayo Clinic in Rochester.
Mayo doesn't have the expertise.
U of M.
Mayo does not have the expertise in advanced prostate cancer. Okay, there are people on this call who go to Mayo. There are doctors who do treat it there. But but they really don't have the medical oncologists. And don't even, and if it were me, I wouldn't even think about Mayo.
Antonarakis is the best. He's the man.
Okay. Okay.
And I was able to get an appointment with 2 weeks, 2 weeks notice, seeing him for the first time. So
okay,
it's not impossible.
I just want to say that my husband is split between the two systems because Dr. Antonarakis is absolutely amazing for kind of the medical drug aspect of it, but the oncologist we were referred to at the university would not do the aggressive radiation therapy that Mayo would. So that's why we're split between the two. Is because they just would not do the brachytherapy, which was highly recommended to us, and we had to do Mayo for that.
Okay.
Well, it may be because they don't have the expertise to do high dose brachy at Masonic. I don't know. And we can work, we can talk about that, but by and large, or maybe it was seeds that Glenn had. I forget. I know I've heard you mention this before, and they may not have had the expertise to do the seeds. But by and large, for advanced prostate cancer, you want to be at Masonic rather than at Mayo. With the greatest of respect to Les, that's where I would want to be. That's where I would want to be.
So Peter, that's the best advice we can give you right now. Get a second opinion from a real expert. I mean, you've been in this battle for 6 years now, starting out optimistic and then going downhill a little bit. So, and you've done all the right things so far, but there was better treatment options.
Okay.
Just get a second opinion. Stay with us. Let us know what you come up with. We meet every week, and put your email in the chat window. Those who are new here, put your email in the chat window, and I'll keep in touch with you. I'll be back in Minnesota in a couple of weeks.
Okay.
And I'll keep in touch with you. Okay.
Sounds good.
Let me just say, I put it's Emmanuel Antonarakis, who is he's going to be the new lead. Charles Ryan, who was the old lead, who we know very, very well here, is now the new head of Prostate Cancer Foundation, and he's slowly turning everything over to Dr. Antonarakis, who we've worked with for many, many years too. Stuart Bloom is another doc who looked after my co-founder, Rob Boniscus. He was at Minnesota Oncology. He's now moved over to Masonic. So if for any reason you cannot see Dr. A, then consider Dr. Bloom because he's good. And I think there's a third one too, but off the top of my head, I can't think who it is. But I heard that somebody else they'd recruited somebody else who's pretty good there too. So that's what I do. And just a word on what Peter said. If any of you are not receiving our reminder, you can either put your email in the chat window, you can send it to Peter or I, or you can go on to our AnCan.org website and register directly on there. But we'll make sure that any names that are on here are getting our reminders.
Okay. Thank you very much, Peter, for joining us. How did you hear about us? How did you hear about our group?
Through Steve Rockland.
Oh, I know Steve. Yes, Steve knows me very well. Steve knows me very well. I've had lunch with him. I biked around one of the lakes with him. You know, we know each other. Okay. Next on my list, Ed.
Yes, here.
Yes.
That's me.
So you got the drill. Where are you from? Fort Myers, Florida, you said. And how old are you?
Yep, that's correct. I just turned 70, April 4th.
Okay. And first diagnosed when?
2017.
2014.
I'm sorry, my wife's correcting me. 2014.
Oh, like me, 8-year survivor. Okay, and you've probably been through all kinds of stuff. What was your PSA or your Gleason score diagnosis?
My PSA was 14.3 at that time, and my Gleason score was a 7, which was a 3+4.
3+4. So I'm imagining it's you've got recurrence. If it was originally a 3+4.
Correct.
Okay.
Correct.
What kind of treatments have you been through?
Initially, I had 45 radiation treatments to the prostate for 9 weeks. And my PSA went down to undetectable. Also, initially with that, I had Lupron injection, 2 of them.
Yeah, I think you did, honey.
2 Lupron injections.
6 months apart.
And my PSA went down to undetectable, and it stayed that way for several years.
That was 2015 when you had those radiation treatments.
I had the radiation treatments in 2015. And a few years later, I had a PET acumen scan and a bone scan. The bone scan was clear. The PET acumen scan showed some activity in the lymph nodes near the pelvis. Followed up with 22 treatments, radiation treatments, April and May of 2021. And PSA went back down, not as low as it was, but it went down to, I want to say like 1.2. And then after about a year, and I had another PET acumen scan. It showed activity in the seminal vesicle. And at that time, I had 5 radiation treatments. They were specifically targeted to the seminal vesicle. And
that was January of 22.
That was January of 2022. And my PSA went down, and then it went back up again, and it was at 5.8. and my doctor, who is with Genesis Oncology. Do you ever hear of Genesis Oncology?
I haven't, but I'm sure somebody has here.
Yeah. He suggested that I get a PSMA scan. I got the PSMA scan, and it came back and said that, well, I got it on just on 6/15/22, and the scan showed that I had activity in several of my lymphatic system, just to be general, instead of saying anything specific. There's several places it showed up, but not on any organs or bones.
Good.
And doctor told me to start Eligard injection, 6 months. Apparently, it would be a permanent thing. I'd be getting the Eligard injections every 6 months, and he started me on Erleada, which I started 2 weeks ago. Apalutamide.
Right.
That's where I'm at.
Yeah. So
Stay away from those 6 month shots. Tell your doctor that you don't want 6 month shots, you want 3 or 4 month shots. Reason is that the 6 month shots tend to be less effective in the 5th and the 6th month. We've seen it here. And so you're better off, if you're going to stay with this doc and you're going to stay and see how you do on an LHRH drug plus apalutamide, to get shorter shots, to get the 3 or the 4 month depot shots. 6 month depot shots, they just don't work that well.
do you know who your doctor is, Ed?
Yes, it's Dr. Chandra Cross. Chandra Cross.
Okay. And is Dr. Cross a genitourinary medical oncologist? They specialize in prostate cancer, or a general oncologist?
No, he's a general oncologist. He treats several cancer conditions.
Okay.
But he's very well versed on prostate cancer, and he treats it all the time, and I've been following his advice.
Right. So just a couple of quick comments here. So, I mean, you were diagnosed about the same time I was, very similar, although I had surgery, then I had follow-up radiation. You've gone through a lot of radiation. And when people come on saying they're going to do 45 days of IMRT or 39 days like I did, one of the first questions we always ask them is to ask their doctor if they're getting pelvic girdle radiation. And it sounds like you did not. It sounds like all the radiation was probably to the prostate, because they had to go back and find, when the lymph nodes started showing up in the pelvic area, they had to go back and radiate those. So it's why we always ask people, whether they're radiating the pelvic girdle or not, because back in those days, it wasn't standard stuff sometimes. But fortunately for me,
22 to the prostate directly, and then 17 to the surrounding area.
Was it?
Yeah. I mean, I'm sure I have that in the notes here somewhere already.
My wife's saying that it was 22 directly to the prostate, and then 17 or something like that to the surrounding area.
Yeah, but you see what they do with that treatment is they go in a very limited field. So they're giving you that treatment to the gland, and then they're radiating the bed. And what they never did is they never radiated the girdle. And to be honest, they didn't do a very good job in radiating the gland, because you got recurrence in the seminal vesicles. That should never happen, because they're supposed to cover the seminal vesicles even when they cover the gland. So it's really hard to understand how you ever got recurrence in the seminal vesicles. But that's water under the bridge. I think the best advice we can give you now is, number one, we'd like to see you get your care supervised by a genitourinary medical oncologist and not a general medical oncologist, because they don't keep up on the literature, as we've already said. And the guide on that is when you tell me you're getting a 6-month shot. 6-month shots, unless you have a need for it because you live in another country or you can't get to a doc that often, 6-month shots are not smart because they're ineffective at the back end. They don't keep your testosterone well controlled at the back end. And so if you can get yourself, if you can start thinking about where else might you get treatment. Fort Myers is a tough place in terms of accessing a good GU medical oncologist. The closest would be probably in Miami, where there is a really good guy who's recently taken over at Sylvester at University of Miami. Or Moffitt, we're not super impressed with, but there are docs at Moffitt. Otherwise you've got to go.
Tampa, sir?
I'm sorry?
Is that Moffitt in Tampa or Clearwater?
Yeah, Moffitt is in Tampa. So, but we can work with you to find somebody at Moffitt, but frankly, you're better off going across to the East Coast and going to the guy at Miami whose name I can give you in a second.
Len, do you have any suggestions on this, or Al, for docs?
Well, Peter, unfortunately, the doc I was seeing in Sarasota switched from prostate cancer to ovarian, female genitourinary oncology. So otherwise, I'd recommend her. She's about the only one I would recommend.
Anybody else? Anybody else with Florida roots have any experience?
We went to Cancer Center of South Florida when we were in Florida during the winter. I'm looking for the doctor's name. We liked him very much, but we really liked his PA extremely.
Right. But again, with an 8-year battle going on here, you want to have someone really knowledgeable on this, so that
He was a prostate oncologist.
right, good.
Okay.
Well, if you can come up with a name, Linda, that would be great.
Okay.
Hey, Peter, this is Bill. I have 2 friends that both got treated at Moffitt for their prostate cancer, but they both had prostatectomies and then recovered nicely, and they have had no recurrence, but they did like the experience at Moffitt. I'm trying to remember the name of the main doctor there.
Yeah, Bill, the problem is that for advanced prostate cancer in terms of GU med-oncs, that's where the expertise isn't there. So if they did well, that could well be, but that's very different from going in and looking for a good GU med-onc. I'm just looking for this guy at Sylvester, so I can give you his name. We spoke to Al. Al Latimer, do you remember the name of the guy? Not the Indian fellow who goes on vacation all the time, the other guy?
I know you told me his name and I was going to go back and look it up, but I don't see it right at the moment.
I'll find it, don't worry.
I've been seeing Singal for a while now. I'm pretty happy with him. On the other hand, he went back to India on Friday, so I'm interested in the other guy's name too, because this is my chance.
I'll just give me a second and I'll find it. I know how to Google it. I've actually got it. I've got it bookmarked, but you've got to remember his name to find the bookmark.
So Ed, let me just say, you don't need to go to see a doctor like this, a specialist, every week or every month or even every 3 months or 6 months. You can do it online. You just need to be in their care and be on their radar. I live in Hawaii, and it's a wasteland for specialists in prostate cancer. My doc is in California, and now I've got another one in Minnesota. I'm willing to travel when I need to travel to meet with them, or I do it online, and they stay on top of my disease. And I've been fighting this the same length of time you have. I've been through radiation. Everything that for me is in my lymph nodes as well. And I stay on top of it. So again, it's worth finding, even if it's out of state, it's worth finding a specialist genitourinary medical oncologist that will really be your guide in this thing, because you're in it for the long haul and you want to get the best care you can.
Yeah, I definitely want the best care I can. But,
What are they saying? Geneva urinary medical oncologist?
Someone will put it in Genito, GNITOURINARY, genitourinary.
Okay. All right, I've put both genitourinary medical oncologist in the chat window. Oh, of course, you're on the telephone. Yeah, it's really better to join us through the computer because you can't see the chat window on the telephone. It's genitourinary. It's a medical oncologist who specializes in cancers of the genitourinary system, so that would include prostate. The doctor that we like at the University of Miami, his name is Bilusic, Bilusic. And I think that that's probably the closest. We can certainly recommend other docs, but I think that that's probably would be who we suggest.
Unless you want to go to Houston.
Yeah.
Docs there.
Well,
Dr. Bilusic, Bilusic.
So are you saying that the treatments that are being recommended by my oncologist are not what they should be, basically?
Well, what we're not specifically saying that, and again, we can't give you medical advice. We can tell you what the protocols are. First of all, it's very good that you are on an LHRH drug and a second-line anti-androgen. The issue is that the LHRH drug you're on, the 6-month depot, is not a good shot. It's just not that effective, number one. Secondly, why Dr. Chandra started with apalutamide rather than abiraterone is a question that should be asked, because we know it's better. The research says that it's better to start with abiraterone than it is to start. Now, you may not be a candidate for abiraterone, in which case it's understandable.
What is abiraterone?
If you have abiraterone is another drug.
Zytiga, it's called Zytiga.
Okay.
Zytiga.
We really have to. I'm afraid we got to move on, Ed. If you come back next week, we'll talk to you more. But we've got a lot of guys to get around, and that's one of the reasons we send people to genitourinary medical oncologists, is because they really know the system. They know what's going on. This field is moving very, very fast. If you don't stay up on the research, you're not going to be recommending the right treatments.
Okay. As Rick said, we're going to move ahead. So keep up with us, Ed. We're here every week.
Thank you very much.
Dan, if you can hold on till next week. We've already had 3 new people, and usually that's about the limit, because there's a number of people who are on every week who want some time to update and so forth. So if we can get you at the end here, Dan, we'll do that. If not, for sure next week. So David Muslin, you were the first one that you want to bring something up.
All right, so just I had on Saturday night, I was driving downtown and I lost vision in one of my eyes halfway down. And it turned out to be a TIA, which is a mini stroke, or is a mini stroke, but very, very temporary. It turned out that I was fine. I had no other clots in my body. And I have a history of AFib, and when you have AFib, you're really supposed to be on a blood thinner, which I was supposed to be on, but I blew it off from my doc, and now I'm back on blood thinners, and I'm lucky. It was a shot across the bow. And yesterday, I spoke to Rick. Rick suggested that U of C, Dr. Shmulewicz, they have a program of what's the program called? Cardio-Oncology. Cardio-Oncology. And I actually sent Shmulewicz a note telling him what happened, and he said, "You probably don't need to see those guys, and I think you're on the right, you're on the right drugs right now. Stay on them." But that's what happened to me. So it doesn't look like it's related at all to my prostate cancer. It's really related to my AFib, and I was dealing with some other stuff, and I just blew off the drugs, which I normally don't do. And so I was really, really, really lucky. And but I called my doc right away when I saw the vision in one eye go down halfway, and it was gone in 5 minutes. So I'm a very, very lucky guy and very grateful. I just wanted to bring the group up to date on that.
That's what got Ram Dass years ago. They told him to get on blood thinners. He didn't, and sure enough, he had a stroke. Yeah.
Peter,
Messing around with.
can we?
Yes, let's stay with this. Joe, you had a scare too on this.
Yeah.
Okay, right?
Just a touch. The quick of it is that I was having some symptoms, tightness in the chest, and what else? The shortness of breath, those kinds of things, and of course the tiredness, which I had just come off of ADT, so I was attributing some of that to it. So what we did is we went and did a nuclear stress test, which involves a series of scans as well as a treadmill time, and I was unable to complete the treadmill because of the tightness in the chest. It came back up after about 6 or 8 minutes, which is not sufficient. So the next step that I went to was a same day, a heart catheterization. They were suspicious that since I was 12 years out from my bypass, that maybe one of the bypasses was failing. Well, the good news and the bad news is that everything was okay, which makes it the bad news of, all right, now we got to figure out where we're going. So I will be doing some consulting as well with a cardio-oncologist in conjunction with the docs that I'm already using.
So I hope everybody has a cardiologist at least. I mean, some places you can get a cardio-oncologist, but at least I hope everybody has regular heart checkups, because that's the #1 killer for guys. I mean, yes, prostate cancer is serious, but with the drugs we're on and so forth, you need to keep track of the heart stuff. Anybody have a comment about that?
Yeah, I do. I agree with Peter. Particularly, there's a list of drugs, few of which we use in prostate cancer, that have just come out as needing an echocardiogram and a specialist. I'd be interested to know, was it Joe that said he was going to find a cardio-oncologist? Who and where did you find one?
Well, I've located one. My cardiologist is actually as a head in interventional cardiology, but since he is away on vacation now for a couple of weeks, I'm putting something in my hip pocket. I'm at Fox Chase, which is under the Temple system, and Temple has a one or two people. This one woman, Hamid, who is a cardio-oncologist.
Hamid is her name?
Hamad.
Oh, good to know. Okay.
So I'm going to probably use her for a second opinion. Not that I don't trust my guy, but as we talk in AnCan, second opinions.
And you said you're done with Lupron now?
I'm sorry?
Did you just say you're done with Lupron?
It was Orgovyx, but yes.
Okay.
Orgovyx and abiraterone. Okay, and I just came off of it. And the thing that helped me come off a little bit earlier than normal would be I had a clear PSMA PET from last year.
Okay. Oh. So you're not on any meds now?
Other kinds.
Other kinds, yeah, but not at,
Yeah,
okay.
they put me on a beta blocker, and
Yeah.
the aspirin and
So
all that.
I want to wade in here because it's a concern to me. These heart and stroke issues that are coming up. There's been a couple of others too where people have talked to us, and one of the things that one of the reasons why I suggested a cardio-oncologist is because the cardiologists themselves may not be fully aware of the effect of the hormone therapy drugs that you're taking. And we certainly know that the LHRH drugs are pretty strong and they do have an adverse heart effect. And we also think that some of these second-line antiandrogens can contribute. And I suppose that between the cardiologist and a good GU med-onc, which Russell Shmulewitz certainly is, that they can take care of it. But I also wonder to what extent the GU med-oncs are keeping up on these heart issues, and this cardio-oncology specialty is becoming more and more common, certainly in the centers of excellence. I looked at 3 or 4 different centers of excellence last week, and in each and every one, there was a cardio-oncology specialist. And so it's not hard. I mean, my guess is that Yale, Dr. John, I think Yale will have somebody. If you look at Yale under cardio-oncology, they will have someone. And I think most of you, if you're at a center of excellence and you search for cardio-oncology, you'll find that there is a specific doc there. And if it were me, I would want to talk to them because I think there are nuances around long-term hormone therapy that may not be appreciated by the GU med-oncs, just the same way as we think if you want the best pain medication, you need to see a palliative care doc because the GU med-oncs can't keep up with some of the new pain medications. So as a principle, we'd like to see the best specialists involved. Now,
the advantage I have, Rick, with this, as I think I sent you the note back, under the umbrella, another hospital is Gents, which is where this woman is primarily based, but it's literally across the parking lot from Fox Chase.
Right. But she advertises herself as a cardio-oncologist, which is great.
Okay, so I'm going to get her talking with Gynasman as well.
Right. So sometimes you've got to lean on your docs a little bit and say, yeah, but what about having been on hormone therapy for the last X number of years? I mean, I had a guy this week come to me, and he doesn't want to get off of hormone therapy. He's been on it for 8 years, and I said, you've got to talk to your doctors about the impact on your heart, and please mute if you're not. Please mute if you're not talking. So one thing that we're doing, we're working right now with Narayan, Vivek Narayan at Penn. In fact, Dr. John is doing this, and I'm going to give Dr. John some news he hasn't heard because I only found out this morning. But we're working on getting a study financed, a grant for a study to spread the word about cardio-oncology, and the grant has been funded. I learned this morning from Dr. Narayan. So we will be doing more work in this space. Dr. John has been wonderful in terms of coordinating with Dr. Narayan and Dr. Leung, and we see this as being a really, really important issue. We will be coming back to it, but it should be on, as Peter correctly said, it should be on everybody's radar that, you know, you've got to be concerned about your ticker if you have advanced prostate cancer because of the hormone therapy drugs that you're taking that may increase risks for heart and stroke conditions.
Hey, just to point this out, I've been on Zytiga for almost a year and a half, and for the last 2 months, I've been fighting to get my blood pressure in check, changing drugs around, trying to get it right. And a couple of days ago, I was below 100 systolic and below 60 diastolic for a whole afternoon and evening, and I had no real problems the first year and maybe 3 months, but it really can come after you.
What drug was that, Jeff?
Zytiga.
Zytiga.
Yeah, and you know, one of the reasons with the Zytiga is not just the Zytiga, but the steroids can have an impact too, because you have to take steroids with Zytiga. Who else? Someone else wanted to talk about, had something to say on this cardio-oncology.
Rick, this is Al. I wasn't the one, but I have an appointment with my oncologist or my cardiologist next week because I've been concerned about all the stuff I've been going through recently. But I didn't know about a cardio-oncologist, so that's very interesting information. Thank you.
I bet if you, I can't do it right now, but I bet if you go to Sylvester Cancer Center and put in cardio-oncology, they'll have a group, Al.
Oh, well, I did that already and it said no results. I'll keep trying.
Okay.
You can get
If you don't have one, buy a cheap monitor, an inexpensive monitor at the local drugstore, and just track your blood pressure. Don't just wait for a doctor's appointment to do it.
Yes, Peter, I do that, and it tracks them on my phone. I see the complete history on my phone.
Great.
And there's a couple places you can get a nice little primer on cardio-oncology too. One is on AnCan, where Rick's buddy, Dr. Leong, gave a talk last summer. And the other is, Rick, what's the name of Priya's organization?
Oh yes, that you appeared on Cure Talk.
Cure Talk. You can go on Cure Talk and get an introduction from Dr. Moslehi, who went to my medical school, about it as well. Just these two guys alone have published about a dozen papers in 2022 alone on cardio-oncology.
Right.
So I'm sure that Joe is actually chasing down the link to Dr. Leong, and he'll put it in the chat window for you before very long. So keep an eye on the chat window for Dr. Leong. And the Cure Talk, if I can, I'll try and find it for you. But yes, our own Dr. John Antonucci was on a panel on cardio-oncology.
Wearing a tie.
Yes, we're very, very, very proud of him.
David, did you say you were driving when you lost your sight?
I did.
You were
but
one.
The good news, I only lost my sight in one eye. My other eye was fine. I just closed one eye like I do when I drink too much, and I just kept driving down the street. I'm just teasing. It lasted for 5 minutes, and I was really able to see. I stayed in my lane, and I was okay. But I would have pulled over. It only lasted about 5 minutes.
Let me just say, this man was a hero because his wife was sitting next to him and he didn't want to say anything to her. So he didn't even let on that he could only see through one eye.
I don't know if that's being a hero or not. I question that.
Kind of an idiot hero.
I would have pulled over and said, please drive.
Well, may you never have a stroke, David.
Yeah, well, I'm lucky. It was a hell of a warning, and and I had a reason for not telling her, but because I wanted
Can't
to
you-
travel the next day. I wanted to travel the next day, and I knew if I told her, I'd be out. So I figured I had to figure it out on my own, and I did about 10 minutes later. Then I
Can't you
came
get
clean.
rid of your AFib? That's what's causing these things.
Yeah, the AFib comes in and out. It's you know, sometimes I don't have it at all in a year. Sometimes I'll have it twice, and the AFib episodes usually don't last for more than an hour or two.
Oh, I see.
So it doesn't stay in AFib. I come in and it converts out, and I can feel it really when it's in.
I
So,
see. So you can't
but
just
I
get
still
it
need to
converted
be,
and stay converted, yeah.
Okay, I want to move on.
it's
to other
thank
guys
you.
here. Tom Jacobson. Tell us what's going on.
Yeah, well, I have too many things now because we're running out of time and I want to be respectful of other people's time, but there are a few things. I'm curious about, I'm assuming a lot of the people here have been on ADT at one time or another, or maybe still are.
Yes.
I thought it would be interesting just to see a show of hands of who is or has been on ADT.
It's easier to say
Everyone,
who
Tom,
has not.
everyone.
Okay. The reason I'm asking is I'm interested also in the maybe side effects of ADT after you've been on it for a while. And one of the things, I've been on it for a little over a year now. And one of the things I'm experiencing right now is pretty severe aching legs, radiating from my right hip down. And I don't know if that's the cancer itself or if that's a side effect of the ADT, both or what. And my oncologist doesn't seem to know either. He took me off of Zometa just temporarily, which I was taking just to boost up my bones. So I'm curious if anybody else has experience along that line, because it's pretty painful. And I just read a study, I think yesterday, about a correlation between rheumatoid arthritis and ADT, which is pretty concerning. So I was wondering, does anybody else have that experience?
I used
with
to
ADT?
call it Lupron legs.
Yeah.
Yeah. Anybody else experience that? Where you're yeah, it can be pretty annoying for sure.
Sounds like
it's more
Huh?
It's more than annoying at this point. It's really painful, and it started out kind of annoying, and I've just, I don't know whether to think this is just cancer taking over, or what do we got going here? But I hear
You had a scan recently?
Can you turn it?
No, I had a scan in November, and that was a follow-up to the one I had in April of last year, and it actually showed the tumor sites were shrinking, and my PSA is undetectable, but still I've got that sort of nagging doubt in my head, like what's going on here. So thought I'd throw it out to the peanut gallery.
Could I tell you what Dr. Antonarakis told me yesterday?
Please.
I recently started abiraterone, and he suggested that we might be able to reduce the dose. He said that I think the Propel study is the one that is the most relevant. He said that they tried 500 milligram, 750 milligram, and 1,000 milligram doses, and that the 750 wasn't much better than the 500, and that the 1,000 milligram dose wasn't really much different. And so if a lower dosage would help you, you might talk to your oncologist and see if that's a factor.
Yeah, I'm not taking Zytiga. I'm actually taking enzalutamide, which is another question for Rick. But I'm playing the same game with enzalutamide. They tell you to take 4, and I'm taking 3. Why am I doing that? That's my own stubbornness, I guess. So I'm taking enzalutamide and I'm taking Orgovix. I got off of Lupron, wondering if that was. It's funny to hear Peter you say that Lupron legs, because I was wondering if that was causing it. So I'm on Orgovix now, fairly recently, and plus enzalutamide, but I've still got this dull ache, and it feels to me like people describe arthritis, but I don't know that. So anyway, that's it's a question, a dangling question out there, but I was interested to see a paper that did have a correlation between ADT and rheumatoid arthritis.
Well, these drugs wreak havoc on our bodies, and probably not one of us has not had weird thoughts about, don't tell me I've got bone mets, and don't tell me I've got something going on in my spleen or liver or whatever. It's your mind gets really rolling with this stuff. I know mine did and still does sometimes, with every new ache and pain.
Yeah, I don't think that the rheumatoid arthritis is, and I've seen that paper and I'm aware that there is now more of a link with respect to rheumatoid arthritis associated with ADT. I think the issue is probably more related to the fact that your muscles tend to waste when you're on ADT unless you're doing aggressive exercise. And so what you're feeling is changes in your muscles as a result of having no testosterone in your body. And I think that's a little different to rheumatoid arthritis, which has more to do with the joints. But I'm not a doc. I'm not sure about that. I don't know. One of the docs on the call, other John?
You're right, Rick. Rheumatoid arthritis is an autoimmune disease. I mean, I was just looking through Lupron adverse effects, and it certainly says muscle pain, limb pain, joint pain, muscle atrophy, all that kind of stuff, but it doesn't say anything like rheumatoid or autoimmune arthritis or autoimmune myositis or anything like that. So I would go along with what you said, and I probably wouldn't call it rheumatoid arthritis.
Yeah, the rheumatoid arthritis is a new study that came out relatively recently that I've seen pointed to in a couple of different places, but I don't think it's got a lot of traction at this point in time. The study got traction. I don't think the concept has gotten traction, John. I do want to say
that's exactly why I'm asking.
Right.
Yeah,
I do want to say
because
that
I couldn't find very much on it.
Yeah, because it's new, and I'm not sure that a lot of people are really buying off on it. And I haven't read the study, but maybe Herb or Len or John will read the study.
I'll check out the study and see what I think, unless Len wants to do it, and I'll get back to you.
Okay.
I can send you guys the link if you're interested.
Yeah, put the link in the chat window, so it'll save me. I have linked both John's Cure Talk appearance with Dr. Moslehi and also Dr. Leong's webinar to us on hard issues. Both of those are now in the chat window, so you can click on them and listen to them later if you're interested.
Okay.
Okay. Tom, we're gonna move on a little bit, but it's a legitimate concern. Almost every one of us, I'm sure, has gone through this stuff, and it's annoying. It's hell going through. It's nothing to take lightly. Carl Foreman.
Hello. I had a whole bunch, but I'm down to one now. There's a location in Scottsdale, Arizona that has a presence on the internet for special type of treatments for prostate cancer and targeted therapies and specific types of chemotherapy. And it's called Envita, E-N-V-I-T-A. So I don't know if Rick, since you're in Arizona somewhere, if you had heard of them, if they're, shysters or not, if you know.
I read that same article in Vita. Yes.
I don't think that there's a lot of, I have looked into them. I have heard of them. They don't carry a lot of weight for me personally. Let me say that. I'm not going to say they're shysters, but you wouldn't find me going to that clinic. It's a lot of money, not for very much. And it doesn't seem to have a lot of real evidence outside of people in the Envita clinic wanting to sell their process.
Okay, good enough for me.
I have one friend that went through it, spent a lot of money, didn't really do much. He's no longer with us physically. I think it was the wrong track for him, but I couldn't say anything. Ken, are you familiar with this place? You're from Scottsdale.
Asking you a question.
No, I don't think he's asking me.
Ken?
No. I've never heard of them.
Okay.
I read about them.
They're there, Ken. You can track them down, man. I don't think they'll impress you that much. Take a look.
Yeah, I just want to also quickly get back to Tom, where you're talking about radiating pain down the leg. I did have that. I was put on a medication called gabapentin, which is for nerve-related, possible nerve damage. And I was on it for over a year, and it did help me.
Right. Cramping is another thing.
Thank you. I'll look into it. I've tried it and didn't do anything for me, but maybe I didn't try it long enough.
Muscle cramps is another one that gets you too, with these drugs.
Yeah,
Okay.
muscle cramps, definitely.
Yeah. Is that it, Carl?
Yeah, that I got more, but I'll leave it for some other people.
Okay. Larry Fish,
yes, thank you.
You with us?
Yeah, I'm here. Hi, everybody. I'll pass my time tonight, and I'll come back. I'll talk.
You'll pass your. We never hear from you, Manish Tana. What is going on, Mr. Fish? You never ask the time.
All right. So last Wednesday I had a Polarify scan, and I had a doctor meeting today. It turned out that my PSA has been slowly rising, and the Polarify 7.8. My Polarify scan showed a increase in growth in the prostate and at T6. We were discussing what I'm going to do. I've been on Lupron over 6 years. Really is my main treatment. So, doctor wanted to refer me to take a couple of targeted scans for the T6 in the prostate, and then send me to a radiation oncologist, and thinking to try to zap those spots and maybe hold off on the second line androgen. My feeling was I wanted to add darolutamide immediately and then look into the radiation. Finally, we settled on an aggressive approach where she's applying for the darolutamide. It can be difficult with my insurance company, just because they're difficult about everything. We had a long fight with Polarify. They denied it. They wouldn't do it. Peer to peer. finally it went through. But they've been denying things right and left every time there's something. Getting bone scans. 6 years. All of a sudden they started denying my bone scan. That was a big time. And she's expecting difficulties, but she's ready to fight on. And anyway, what we decided was in a more of the combination aggressive approach, which is that I would start darolutamide as soon as she can get approval and they call me to deliver it. And then I would go for the MRIs, which she says are easy to get for the spine and the prostate, and look to radiate both those spots. Underlying all this was, my long-range plan, which was to use darolutamide as a monotherapy and try to take a vacation or holiday from Lupron at least to begin with. That's why I wanted to get the darolutamide as soon as possible, because it's 6-7 weeks for my next Lupron shot. So my hope was that PSA would go down, and she thinks that probably will happen. And so my plan is to just skip my next Lupron shot, see how it goes while I go through the radiation. Anyway, that's where I'm at with that progression. It didn't surprise me. I'm glad it wasn't worse. I can handle those radiations. Sounds promising that I'll be able to get this under control, at least for some time. Anyway, that's my.
Okay.
Good.
Well, we're happy to hear that it's all pretty limited. We're happy to hear that you've gotten Dr. Audio to apply for darolutamide for you. And maybe we'll get you onto monotherapy, darolutamide, a little spot radiation, and that should keep you happy for another couple of years. That would be great.
Exactly where I'm leaning, because I'm afraid of taking, both androgen, both APPs at the same time. I'm still working and don't want to suffer double effects. It's still challenging, but I'm going strong at work, and I want to keep it that way. Then I'll follow up. Just letting you guys.
You'll be a lot happier just on darolutamide than with
I-
Lupron. You will be a lot happier just on darolutamide than doing Lupron.
Yeah, I hope you're right. She's had cases. I mean, they always use this as the argument, the blood-brain barrier argument. But she says she's had cases of people who've gone to darolutamide and suffered real brain fog as a result also. So she knows and uses this as an argument, but is not 100% convinced that darolutamide is much easier, although from all the evidence I hear it is. That's my plan. She's not willing to say, I stopped the loop. I just keep saying it, and she doesn't respond exactly because that's not their protocol. But I just won't go to that shot. Next shot, if I yes, they won't.
What about that business of ADT working synergistically with radiation? Does that apply to spot radiation too? And if it does, shouldn't you wait till the radiation's done before quitting Lupron?
That's a good point. We didn't discuss that part of it. I just want to get onto the darolutamide and off Lupron, not have them go evaporating for as short a period of time. That was my thought. I'm going to bring that up with her. Thank you. Is that synergistic? She sees.
Are good, Lars. 6 years on Lupron, that's a long stretch.
It was hard. It is hard.
I know. I think there's nothing wrong with a vacation once in a while.
No, I'm all with you, Peter, on that.
But I'm not telling you. I'm not telling you what to do. But I did it. I jumped Lupron a year ago.
Yeah, no. To the guys. I mean.
And Larry, also maybe an appointment with the cardiologist or the cardio-oncologist.
Yeah, that's a new one. I hadn't You know, there's a lot of stuff I'm trying to undertake at the same time. I might want to postpone that till after I start getting through.
Okay, but don't put it out your memory because you know you heard what happened with David and Joe, so we
Yeah,
want you to keep it on your radar, okay?
it is. I'm scared. I feel like I'm at risk of being overweight and diabetic.
Okay, take care, Larry. Keep in touch
A lot.
with us. Okay. So I was
Yeah,
gonna go to,
take care. You know we love you. We know that gravel voice from Brooklyn. Well, where would we be without it, man?
No, I haven't. Don't say that even. Don't even think that. Not,
Okay. Well,
not,
don't you think about putting off the cardio-oncologist then? I'll make a deal with you, okay?
no, no deals. The deal is you'll hear my voice and going about my stepwise fashion. But I'm being
Okay. All
more
right.
aggressive. I'm being more aggressive right
okay. So I was gonna go to Ken Anderson next, but he just dropped out because we haven't heard from Ken in quite a while.
now. He's got the best voice of everyone in the whole.
We're at the 2-hour mark, but Tom Sigugrano, I'm not sure I'm pronouncing it right, but you're up. You're the last one.
Okay. All right. Thank you very much. And I haven't been to one of these meetings since probably the end of last year. Uh, the reason for me coming back at the one of the meetings I was at, you guys, Rick mentioned Dr. Guanciale in Sarasota. Well, I immediately called her when you told me, and she took me in that week. And last May, I went to UCLA and got a PSMA test. And the results were that I had 2 lymph nodes and 2 suspicious ribs that flashed on the test. And it was suggested that I have radiation, which I did on the 2 lymph nodes, but UCLA, as well as Dr. Guanciale and the radiologist thought, after speaking with UCLA, they all did, they said, maybe we shouldn't do anything with the ribs. And then I was put on abiraterone, prednisone, and I get a quarterly shot of Eligard. Well, since December, my PSA has been moving. It's been moving slowly. It was started at 0.03. It stayed there. Then it went to 0.4, 0.4. Then it went to 5. The most recently is 0.06. And believe me, I panicked. And I said, gee, something's wrong. Should have done the ribs? I was worried about it. And they said, no, we shouldn't have done the ribs. So I had a meeting with Dr. Guanciale Friday. And I told her, I said, listen, I want to get another scan. So they're requesting another PSMA scan because I'm concerned. And, I heard on this evening, several of you, it affects you psychologically. Well, it's affecting me. Seeing the rise seems like every month it's going up. And even though the number's low, I have a concern. So I was told today that the PSMA test, I believe, was approved by the insurance. So hopefully I'll have it within the next month. But I asked her point blank, I said, is the medication not working? Is the shots not working? I get them quarterly. And they didn't have an answer. And I'm concerned with the bones, to be honest with you. And I asked them again yesterday, did we let the genie out of the bottle? It was 2 ribs that was suspicious and we did nothing. Now what? So we'll see when I get this next PSMA test.
Hey, Tom, you really, less than 0.1 is considered undetectable. But besides that, as low as you are, I'm on Zytiga also. After 1 year, little by little, mine went up to 2.2. I am now at 0.2 and has been there for 4 months. So the thing is, Zytiga, you're really undetectable now, and Zytiga does work, and you should give it time. You're not As I said, mine went all the way up to 2.2 after about a year, and now it's been 0.2 for 4 months in a row. So it goes up, it goes down, and you're so low, it's not time to really be concerned yet.
Well, I'm 22 years out on prostate cancer.
I'm 12.
And I had surgery 22 years ago, 6 years after that. Came back. I had 40 radiation treatments, and now it's back, and I just had 25, and I'm on all this medication. Like anyone else, you worry, and it's been wearing on me. Ever since I saw the last 3 blood tests, I said, I can't believe it. So.
Hey, Tom, one other thing. I went through a lot of rib meds or a lot of scans, and all kind of spots came up on my ribs. I also have a history of where I broke some ribs. But after 3 or 4 different scans, half of the mets that they thought were on my ribs went away, and 2 mets kind of got stronger. So it took my radiation oncologist at the time gave me all, she flipped from one kind of scan to another scan every 6 months. And then they were able to really figure out which ribs had a met. And then they did spot radiation with 3 radiation treatments, and they were gone. So rib mets aren't terrible. And if they keep doing different types of scans every 6 months, you'll figure out which mets are real and which mets are not. Because sometimes it's very hard to tell with the ribs.
Yeah, well, hopefully I have the same result as you. I appreciate that.
Let me say this. First of all, a lot of times it's too difficult to radiate the rib. They don't radiate the ribs because it's very, very difficult because the target's so small. And so, David got it, but I'm sure there are guys on here who have been told they weren't eligible for spot radiation to the ribs. So don't be nailing the docs that they didn't do it. You may not be a candidate for spot radiation on those ribs. Now, the abiraterone, how long have you been on the abiraterone?
Since October. I take it with prednisone.
Right. So you've got to give that abiraterone more time, as Jeff Marchi pointed out, as he did. And frankly, the next thing, if you've got a lot of things and you don't want to hear it, but the next thing could be chemotherapy. And chemotherapy can really work. It can help you. And right now, you can't get to the better treatments after that are available until you've done chemotherapy. Mm-hmm. So these lutetium radionuclide treatments are not available to you. You've got to get chemotherapy out the way in order to get them. So I think that the best advice you've got, and we've said it several times to several guys tonight, is these are very, very low levels. Even though they don't seem so to you, even though, yes, it's going from, what did you say, from 0.3 to 0.6, we get it, but there's
0.01 to 0.05.
Yeah, mine went from 0.03 to 0.06 since last fall.
0.03 or 0.3?
Yeah. 0.03.
Okay, don't even worry about it. I mean, this is the problem getting these super sensitive tests. They should be asking you, we've tried to innovate this. They should be asking the patient if they want to get these super sensitive tests. You're still under 0.1. You're still under 0.1. Mm-hmm. How many guys, show hands, how many guys on this side would like to have a PSA of less than 0.1? How many guys? Huh? So the fact is that the only reason you're making yourself crazy is because you're getting a test that's too sensitive.
Well, I was looking at doubling time. I'm saying, geez, the doubling time.
The doubling time doesn't mean anything at these low levels. 0.03 to 0.06 is not the same as 3 to 6 because there's too much variance in the tests. The tests aren't valuable enough, and Dr. Guanciale should have pointed that out to you.
My My doc said to me, if you got a town with a population of 1 and 1 person comes in, you've doubled the population, but you've only added 1 person, so it doesn't really mean anything.
Thank you.
The
Well,
PSMA
Tom,
PET he can't get a PSMA PET with that low of PSA. They probably won't approve it either. You've got to have at least 0.5 before it can see anything. And when they used to say 0.7, Rick, I guess it's gone down.
Yeah. Bottom line is relax. If it does, you got some time here. Nothing's gonna run away on you, Tom.
Thank you. Thank you.
No, you're doing great. And, come in more often. Come in and talk to us. Come to the Speaking Freely.
I'm
Do
going
some
to all of them,
things.
believe me. I've got them all on my calendar.
So, do some things to relieve your stress. David Moslin gave some great advice earlier on, because you're making the cancer worse when it doesn't need to be. And the abiraterone's doing what it's supposed to do with the prednisone.
Thank you.
I agree with Jeff Marchi. Your PSA does jump around on Zytiga quite a bit.
Don't spoil this moment. It's a great moment.
Yeah. Jeff Marchi, what else you had something else and I skipped you.
Well, we've been discussing some of these issues, and I've run into something that's directly what we were talking about earlier. I was across the street walking. I do it every day. I do 5,000 steps at least. I've got a track. I go around twice. On June 1st, I went around 2 times, and I could not walk anymore without extreme pain. I ended up 3.5 weeks. My doctor says it's probably a bursa. And after 3.5 weeks, I couldn't really walk on my left leg. And the deterioration in my muscle is you can just see it. It's so much thinner than my right leg. And I've been trying to build it up. But what concerns me is the arthritis issue. And we've been talking about it, and they say, well, you get rheumatoid arthritis, but my arthritis has gotten really bad in the last 3 or 4 years. And my left knee needs replacement. My right hip needs replacement. And I can't do that if my muscles are going to go away in 3 weeks. And I've got to build these up. It's probably going to take me 3 or 4 months to get built back up. And I'm wondering, are there drug changes I can do? Does anybody know exercises you can do when you're laying on your back that'll stop your muscles from going dead when it's the leg that you're actually losing the muscles in? I'm real concerned about being permanently bedridden because my joints are going out on me. And should I change from Zytiga to something else that would be less aggressive, at least for a while, and allow me to recover without losing all the musculature, I was going to say.
Physical therapies?
Yes, I'm going to one now, absolutely. And I'm doing exercises. They never end, it seems. Sometimes you spend a couple of hours and you have to do them twice, and at least twice. And it's just, I'm real concerned that I don't know if, am I getting arthritis due to taking Lupron for 5 years now? Is it, is that causing it? But are there any ideas on what drugs maybe I could change to that would reduce the muscle loss so I could get these surgeries?
So I don't know that there's any drugs that are going to affect the muscle loss, because a lot of it has to do with the fact that you don't have testosterone in your body. This is why we always encourage people to do the exercise. The question is, you've got to find exercise and weight resistant exercise. If you're not doing weight resistant, you've got to do it, that you can manage to do. One thing I would strongly suggest to you is a reclining bicycle. Are you using a reclining bicycle?
No, not at this. I've got another type of bike.
Okay,
Another
so
type of
another
stationary
type of bike isn't going to give you the back support that you need.
Yeah, it's both arm and leg.
Okay, so
motion.
there's plenty. Let me just say, Tess, are you looking for the MS group?
I am.
It'll start in about 10 minutes. Come back on in 10 minutes. This is the end of the prostate cancer group. Okay.
Thank you.
Sure. So you can do, there are these machines in the gym where you can exercise your arms, you can exercise your legs, you can get back support. I've seen them. So you got to, are you a member of a gym, Jeff?
No, I've got equipment
So-
here, but
Okay, but the equipment you have there isn't the right equipment to support you when you've got this pain. So you probably have.
no, it's not with the
you-
pain. It's with recovery from a knee replacement and recovery from a hip replacement. Because I'm
Okay,
over
but
the
yeah,
pain.
but Jeff, you're not listening. You've got to build up those muscles to get the before you do the knee replacement and the hip replacement. Isn't that what you just said?
Yes, and I'm doing that. They
Right.
have improved
Well,
already.
So if you use a reclining bike, if you use one of these other types of machines, it'll be much easier and much better. I understand you can't walk. I understand
Oh no, I
hip
can.
replacements.
No, I'm walking 5,000 plus steps a day now. I'm walking a lot.
So what is it that you want?
I want to know what if I need to have my left knee replaced. I don't want to have all my muscles, and I won't be able to use a bike for the first 3 or 4 weeks at least.
What is it that you want from us right now?
Well, to be able to not, what I was saying, would there be a change in drugs? You already said it's the testosterone. Would there be a change in drugs or something else I could do with it? Allow me to build my muscles up while I'm having the knee replaced so that I don't lose, at least 6 or 8 weeks before you can walk normally. And is there a way to build, when you say get the bike, I could get one of those, and that's not a problem. It's just I don't think you can use it after having knee replacement surgery for a while.
No, you won't. You won't be able to use it immediately. But believe me, with a hip replacement, after 2 weeks, as long as you haven't had a knee replacement on the same side, you can be using an exercise bike after 2 weeks. And
it's the leg that's worse. That's the thing.
Well, but you've
The
got to
knee.
strengthen those legs because you
I'm doing
you
it.
gave us a whole rigmarole about your legs aren't strong enough.
Well, I've been building them up since I've only
I'm
had 3 weeks to rebuild them.
Okay. All right. Anybody else got any advice for Jeff? Because I don't know how much headway I'm making.
Yeah, I have some
Go ahead,
advice.
Peter Monaco.
Yeah, Jeff, I had a total hip replacement back in November, and at that point I was on Zytiga and Lupron for the prior 6 months, and I really didn't have a problem. They took me off the Zytiga for all of 1 week post-surgery, and as long as you do your prehab, meaning you build up, you work out. I was going to the gym. I was doing some leg lifts and stuff, a lot of walking, bike, exercise bike and so on. But they give you prehab exercises for you to do to prepare.
Yeah.
And then, so your first 2 weeks post-surgery, it's rough. You're not going to be very mobile. You're just doing the minimal amount of rehab at that point. But to Rick's point, after 2 or 3 weeks, you'd be surprised how much you can do. And before you know it, you can get back on a bike and certainly start doing some walking. And so that's my point is this: don't let the Zytiga and Lupron mix prevent you from getting a needed surgery. I mean, that's my opinion.
Yeah, it's just I lost
Peter,
so much
did you have a professional helping you, Peter, to figure out what to do? That's what I'm worried about.
Yes, I got.
Okay.
Well, the surgeon's office gives you prehab exercises that they approve you do to prepare, and then post-surgery, I had 18 sessions of rehab that was outpatient and 4 sessions of rehab inpatient. That's at the immediate post-surgery help you need is they come to your house and get you off your feet and get you doing exercise. I'll call it that, but it's minimal what they have you do just to get the blood flowing and the muscles activated. But post-surgery, I had a script. I went to a rehab place for 18 visits, and by the time I was done, I was off to Florida, and feeling pretty good. So
So Jeff, are you getting the right professional guidance here? Is that the issue?
Oh no, I have a PT that's that I'm working with. You know, I'm getting back. I still with my left leg can't walk up a step without it hurting. But it's only been 3 weeks. Yes, I'm doing exercises multiple times a day. I'm going to get back. But what worries me is I need to get my knee replaced, and I know it's more than 3 weeks, when you can't walk very much, it's like 6 or 8 weeks before you can do much, and you sure can't walk fast. So I'm looking at deterioration then.
Right. So you're expressing your worries, what you're doing more than anything else right now.
Yeah, and what could be done right to prevent that. That's initially what I said, but I think people didn't quite get it. All right, look at I got the idea.
On the other side, you might feel better once the knee is replaced and be able to do more exercise too.
Well, I had my right knee replaced, and it was at least 2 months before I could do much. It was, but I had to do exercise. I mean, there are exercises before. I do have in-house, PT, and there's exercises after. But the muscle loss is going to be so big that they tell me I might be unable to get out of bed, and it's just one of these things we'll have to face with all these drugs we're taking. Thank you.
Okay, well, we wish you well on this one. It's additional stuff. The last thing we need is additional stuff to worry about.
Really.
Because we're going to have to call it a day, but I know there are guys that had questions we didn't get to. If you let us know who you are, send a note to herb@ancan.org. herb@ancan.org, because Herb's moderating next week. So if you were on today and we didn't get to you, we'll give you priority next week. That's the best we can do, but we got to close the room down because we've got, as you saw, we've got an MS group starting in this room very soon.
Thanks very much, guys.
We're like the Moulin Rouge. We never close, right? 24/7.
Great meeting, everybody. Great meeting.
Take care. Thank you. Thanks, everyone.
Good night.
Goodbye.
Bye-bye.